We've certainly made a lot of progress in advanced pancreatic cancer over the last 5 to 7 years or so. It started with FOLFIRINOX, the triple drug regimen of 5-fluorouracil, and oxaliplatin for treatment, and was followed by gemcitabine and nab-paclitaxel combination. So those have improved our outcomes that we see in the clinic. It used to be barely 6 months with gemcitabine alone, and now we are approaching a median overall survival of close to 1 year with these aggressive regimens. And these have also opened up avenues for treatment advancements in the adjuvant and neoadjuvant settings as well.
Things have changed quite meaningfully and significantly over the last, I'd say, 10 to 20 years in pancreas cancer. In fact, over the last 2 decades, we've seen significant improvement in a disease where the 5-year overall survival rate for all stages was less than 4%. We're getting close to the double digits. We're not there. We're about 8 to 9% and every year improving. Now, that may not seem like a lot because we're still not doing as well as we should compared to other cancers, but this is doubling, more than doubling the 5-year survival rate. And most of it has happened over the last 4 to 5 years. 2018 was a good year, mostly for the early stage pancreas cancers, where we're starting to learn a little bit more about these strategies regarding neoadjuvant therapy, intensifying adjuvant therapy. Survival in the early stage setting is now close to 50, 60 months. Whereby for the longest time it wouldn't budge beyond this 20, 25 month. And a lot of it has to do not just with how well we're doing before and after surgery, but also has to do with the salvage component. We have more options, with nab-paclitaxel, with nanoliposomal irinotecan, with FOLFIRINOX. A lot of these salvage strategies have also helped improve significantly survival. The other component is, of course, we're understanding a little bit better the whole genetic and genomic landscape around pancreas cancer. And we're starting slowly but surely in very small subsets of patients understand what makes sense and what doesn't make sense and how we target them better. We're still away from getting where we want to be, but I think we're on the right track. I think that train that left the station a while ago and has accelerated through 2018 will continue accelerating through 2019. We expect more data about perioperative treatment, so in the earlier stages. We also expect 2 major studies, phase 3 studies, to close down in early 2019 or mid-2019. We may not have results before the end of the year or by 2020, but 2 major achievements, 2 large studies in pancreas cancer, one with a stem cell inhibitor, napabucicin, the other one with a PEC-PH20, that are large phase 3 studies. And we'll also see a lot of movement around the whole question of what do PARP inhibitors add in terms of value to pancreas cancer. Specifically, one study, large study, the POLO trial, will hopefully report in 2019 and will help us understand the role of maintenance PARP following FOLFIRINOX in patients with BRCA, so BRCA1 and 2 mutations. So I think, we will see, I suspect, we will see some movement forward by the end of 2019 and hopefully by early 2020.
The natural history and biology of advanced pancreatic cancer and pancreatic cancer in general have been helped greatly with next generation sequencing using genomic methods and molecular techniques. So we are learning quite a lot. We are learning about the biology and the natural evolution of pancreatic cancer, how there's a lag time between the initiation of disease in the pancreas to the evidence, the clinical evidence of disease in the patient. We are learning about the genomic makeup of the tumor. There are some actionable alterations that have emerged, microsatellite instability, for example, the deficient DNA repair pathways, for example, actionable fusions such as NTRK, etc. But Still, unfortunately, this constitutes only about 1 to 2% of all cases of pancreatic cancer. We still have a long way to go in terms of finding molecular targets that are actionable in terms of making a clinical difference for patients. We certainly need a lot more in terms of predictive biomarkers in pancreatic cancer. Right now, there's nothing prognostic or predictive really, nothing that changes a patient's management for us. We, as I mentioned, microsatellite instability, deficient DNA repair, some targetable fusions, molecular fusions in pancreatic tumors are potential meaningful biomarkers where we can select treatments based on these. But again, these are single-digit percentages, 1%, 2% of all patients. For most patients, we sorely need either a blood-based or a tissue-based or a genomic-based biomarker to be able to better predict who should get what.